In today's Essential Task, we are going to begin our unit on clinical psychology. The majority of our unit will involve looking at psychological disorders, talking about what constitutes those psychological disorders and diagnosing them by identifying symptoms and talking about other characteristics of those disorders, and then eventually transitioning into treatment and treatment methods. However, we're going to begin in 9.1 by talking about concepts and elements of treating psychological disorders and categorizing psychological disorders in sort of big picture elements before we actually get into specific disorders by name. So this background introduction essential task looks like this. We're going to first talk about what a psychological disorder is in the first place, then talk about some elements related to history, classifying, and then ultimately diagnosing. It won't be until essential task 9.2 that we actually start addressing disorders by name. But I'll allow you to pause the video here before progressing into the concept map. We'll go all the way to the top and define psychological disorder. So according to the APA, a psychological disorder is a syndrome marked by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. And this arrow down with that giant word interfere bolded in orange is really important. That subsequently interferes with the life of the individual, meaning for something to be classified as a psychological disorder, it really needs to significantly interfere or impair an element of the individual's life. So we're talking about things like interpersonal friendship and relationships. We're talking about things like hygiene. We're talking about things like maintaining a job. We're talking about things like affecting your education. You could theoretically check off the boxes for the symptoms listed on some of the disorders that we're about to talk about, but if it's not causing interferences with the life of the individual, it might not rise to the level of a diagnosable disorder. It's very important that not only are the symptoms checked off, but there's also this element where those symptoms seem to significantly interfere with the life of the individual. And depending on the category of disorders, depending on the actual disorder itself, that can affect cognition, emotion, or individual's behavior. Proceeding next, or just to emphasize this point. So, for example, a lot of people are afraid of spiders. There is a such thing as a phobia of spiders. If you're afraid of spiders, but it doesn't significantly interfere with your life, it's not likely going to rise to the level of a phobia. For something to be a diagnosable phobia, yes, you need to exhibit the symptoms. Fear and avoidance of spiders needs to be irrational, but it also needs to significantly interfere with the life of the individual. Next, we'll talk a little bit about history before getting into classifying and then diagnosing. So this might seem a little weird, but just to kind of big picture it, back in the day, hundreds of years ago, before we got to the point where we are with medical technology, before we got to the point of diagnosing in the manner in which we do, for a lot of human history, when an individual exhibited symptoms of a disorder, without having the terminology or the background to diagnose and classify, people said outlandish things like the devil did it. And as a result, the treatment, and I use that term very loosely, we involved things like tooth pulling and body mutilation. And for a lot of human history, somewhat recent human history as well, we had really poorly run asylums or medical institutions where, because at this point in our history, we didn't have the pharmaceutical approaches to treat something like schizophrenia, these really interesting and unusual and rare symptoms that would be exhibited when an individual had a psychotic disorder might, at least in the time period, warrant sending that person to an insane asylum because we simply don't have the means of treating them in our community. Well, luckily, we've come a long way since that. Those type of techniques are obviously inhumane. Those type of techniques are obviously not great from a medical perspective. And from a modern perspective, we've really started to see a shift from, I'd say, the late 1800s and then certainly throughout the 1900s, although through a lot of those early years in the 1800s and 1900s, we still saw poorly run asylums. Nevertheless, when Dorothea Dix, a figure you may have heard in a US 1 class when talking about the 1800s and some of the reform movements, Dorothea Dix gave this scathing criticism of the health and asylum conditions that existed at the time in the 1800s. And she, in and of herself, might not be the exclusive singular reason why we've seen such a massive shift. It also is coupled with improvements in technology. But over the course of the last 100 plus years, we've seen some really steady and progressive improvements in the conditions of medical hospitals to a point where, from a modern context, we've really made great strides ensuring that if an individual is going to be an inpatient at one of these mental hospitals, whether it's state-run or otherwise, that the conditions in those hospitals are ideal, that we're not using treatment methods that are inhumane, and that we're doing everything from a medical perspective. In a modern context, when we diagnose and talk about some of these disorders, really the hope is that we can approach these disorders from the medical perspective, where we can identify some type of underlying physical cause and as a result diagnose, treat, and hopefully cure the patients. What we've actually seen is a massive deinstitutionalization, where at one point in time, populations in some of these hospitals, what we would have otherwise historically called asylums, though we don't really use that terminology much anymore, have steadily dropped. We've seen inpatient hospital populations significantly drop, and now we have the means, whether it's through pharmaceutical drugs or through certain types of therapy, for treating these disorders at home, where really at the end of the day is exactly where we should be dealing with and treating some of these disorders. Proceeding onward, we have to talk a little bit about classifying, talk about a critique of classifying, and then finally end our concept map by talking about means in which some of these disorders are diagnosed. The go-to text for diagnosing disorders or classifying disorders is what's called the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, and we are currently on the 5th edition technically. You will see this with a Roman numeral, so the Roman numeral for 5 is a V. I wrote it out DSM-5 just in case you haven't seen Roman numerals a lot, but it is important to know the Roman numeral. We are in the DSM-5, typically illustrated with a Roman numeral. The DSM, whether it's the 5th edition or otherwise, is a text. It's a rather large text, but it's used for classifying psychological disorders. And if you looked into it, you would find great details on every single disorder, from sleeping disorders like insomnia, to psychotic disorders like schizophrenia, to mood disorders like bipolar disorder, to personality disorders, and everything in between. And we revise this fairly frequently. We revised this not too long ago, I'd say about 8 or 9 years from this point of the recording of this video. So we revise it ever so often when there are changes within the field, and things might change, such as determining that there's better terminology that should be used when naming some of these disorders, sometimes shifting around ways in which disorders are classified. For example, the personality disorders had a pretty big shift a few editions ago. Of the most recent editions, we no longer use terms like multiple personality disorder. We now use terms like dissociative identity disorder. So there's sometimes terminology changes. What a decade plus ago would have been called hypochondria, we now call illness anxiety disorder. So there is terminology change that occurs because as time progresses within the field of clinical psychology, we become more familiar, we have a better understanding of these disorders, and we feel like whether it's re-identifying symptoms or simply reclassifying what category disorders fall under or simply renaming them, that these changes are warranted in order to improve the treatment that patients receive. I just want to give you a sample of what it would look like if you looked at the DSM-5 for insomnia. Insomnia was a disorder that we talked about last unit. It was a sleeping disorder, and it's very clearly written here in A what the prominent symptoms are. We're talking about difficulty initiating sleep and difficulty maintaining sleep. Early morning wake-ups I typically classify with maintaining sleep, but it's also important, in addition to that A, that there are A through H criteria for actually going ahead and diagnosing insomnia. B is really, really important. Just a few moments ago, in the very first box of this essential task, we clearly stated that in order for something to be a diagnosable clinical disorder, that it needs to interfere with the life of the patient. Well, notice the B criteria listed right after the prominent symptoms. The sleep disturbance causes clinically significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. That element is very clearly stated on that B criteria. From that point, depending on the disorder, we might add some time frame criteria. I may have mentioned in class that if you have a difficulty falling asleep one night a month, that's not really classifiable as insomnia. But if the sleep difficulty occurs 3 times a week, it's existed now for at least 3 months, you've given yourself the opportunity to sleep, that's an important criteria. If you stay up till 2 o'clock in the morning studying and only give yourself 3 hours of sleep, well, that can't be classified as insomnia. In F, it states it can't be as a result of something else. It can't be better explained as a result of a different disorder. It can't be attributed to a substance like a drug. You can't be using caffeine late at night and then claim that you have insomnia when it might be the caffeine or the amphetamine or the cocaine. And coexisting mental disorders and medical conditions do not adequately explain insomnia, meaning there's not another mental disorder, perhaps depression symptoms that might better explain the lack of sleep. So when you look at singular insomnia, it gives you all of this criteria so that when you're diagnosing, you can be precise why it is that the insomnia diagnosis is appropriate. The idea of using the DSM-5 or labeling individuals with disorders was the primary critique made by David Rosenhan. Rosenhan conducted a pretty interesting sort of pseudo study. It's not quite an experiment. It doesn't quite fit the features or the research methods we talked back in Unit 2, but he essentially did this. He and a bunch of colleagues went to hospitals and faked hearing voices. Well, hearing voices is a primary symptom of a disorder called schizophrenia. We'll talk about schizophrenia in the upcoming Essential Task 9.2. But he acted normal besides that one symptom. Well, he and all of his colleagues were all misdiagnosed with schizophrenia, to the surprise of nobody. And in addition to just being diagnosed, all of the doctors seemingly and clinicians seemingly discovered causes. His concern and his criticism was that when we use things like the DSM-5 to diagnose, that there's this gray area where these labels could significantly distort the perception that whether it's clinical psychologists or doctors or anybody else working in these institutions, could significantly impact their perception of the patients in which they're seeing, where they're looking to discover a label as opposed to dealing with these people individually. To the extent that the Rosenhan study has a major impact in today's world is up for debate. His study now is several decades long. But the idea of Rosenhan's critique is that when we sit and we start to label schizophrenia, mood disorders, etc., that these labels might significantly influence the perception of the medical professionals of the individual in which they are treating, because Rosenhan and his colleagues faked one symptom of schizophrenia, just one, and even though they acted quote-unquote normal beyond the point of that hearing voices symptom, they were all diagnosed. As we'll talk about, hearing voices is only one symptom of schizophrenia, and to be diagnosed, you technically need two symptoms, of which they did not exhibit a second, but nevertheless were all still diagnosed. The last column furthest to the right has two boxes on it. The first is to acknowledge what's called the diathesis stress model. These are under the category of diagnosing. The diathesis stress model argues that the disorders that we talk about in this unit are a byproduct of two different variables influencing the life of the patient. One, their genetics, but two, real-life stressors triggering these disorders. So essentially what this model argues is that individuals are predisposed to certain disorders, that based on your genetics, you're more likely to exhibit a mood disorder like depression or an anxiety disorder like generalized anxiety or panic disorder, that your genetics predispose you and make it more likely that you exhibit some of these disorders. But you could live your whole life without ever manifesting depression or anxiety, that in addition to just your genetics, there's also environmental real life stressors or triggers that could essentially tip the scales and cause you to manifest these symptoms. Meaning, if you're an individual whose genetics suggest that you have a higher likelihood for something like depression, you're more likely to manifest depression. It might take less stress in your life to manifest the symptoms of depression, but it's not a guarantee. There's this balancing act where, if you take a look here at the model visually, that everybody theoretically, according to this model, could manifest the symptoms of depression. But if you are an individual whose genetics suggest that it's more likely, it's going to take way less real-life stressors to actually get to the point of manifesting those symptoms. And if you take a look here at the right, I think this graph does a really good job identifying a real-life stressor and how that theoretically could be affecting psychological distress. If you notice, there's a really strong relationship between income level and psychological distress. Income level is a very great example of a real-life environmental stressor. If we take a look here furthest to the left, if you make less than 100% of the poverty line, there's about an 8.7% chance that an individual within that economic bracket is going to experience serious psychological distress. But then you notice as individuals make more money, between 100 to 200% of the poverty line, 200 to 400, and then 400 and above, the instances of psychological distress drop significantly, suggesting that one of the potential environmental real-life stressors that could be an underlying cause of manifesting the symptoms of a psychological disorder are in fact economic and poverty-related issues. When we go back and look at the diathesis stress model, again, we're arguing that genetics and real-life stress combine to cause disorders. Perhaps, and again, we're using somewhat correlational, though somewhat longitudinal work as well, but not the type of research studies that we can definitively use cause. But just to try and make sort of a prediction here based on what we're looking at, potentially things like economics are combining with the genetics of individuals within those income brackets. And when we combine individuals with a high predisposition for depression and anxiety and other disorders with low income as the real life stressor, Perhaps that might explain why individuals within that economic bracket have a higher likelihood of exhibiting significant psychological distress. The last box is to acknowledge one of the ways in which we diagnose disorders, and it's important to note that this by name might be somewhat confusing because it has the word personality in it, and you might see this and assume this is just a personality test. The MMPI, or the Minnesota Multifacet Personality Inventory, and you typically would see it spelled out with also MMPI attached to the end, abbreviated with that acronym, is one of the most common ways that we diagnose disorders. It is essentially a personality test, but what it's done, or what it's used for rather, is to evaluate overall mental health and other clinical issues. So it's not quite the same type of personality test, but we're trying to determine if you're really conscientious and organized. It might touch upon that by default, but the questions come more focused on things like, are you concerned with body symptoms? Are you pessimistic? Are you hysteric? Are you exhibiting deviancy? As you can see here, when you look at the results on the left here on the y-axis, you'll notice a variety of topics, which, although we haven't gotten into any of the disorders, we will definitely, in just a few days, get deep into ones that involve things like feeling shy, certainly involve things like schizophrenia symptoms, certainly involve things like depression symptoms, certainly involve things like feeling anxious. And what this essentially does is when you take the MMPI, you'll get a score before and after treatment. And the hope is that the scores on some of these shift before and after treatment. So, for example, if we're treating depression symptoms, we would hope that the depression scale itself would drop in the aftermath of a treatment. If that were not to happen, then we would certainly be more concerned that the treatment that we've been using is not effective. If, on the other hand, we see a significant drop, well, then we would suggest that our treatment is in fact working. So we can use the MMPI to identify which of the, in this case with the example here, 10 criteria seem to be elevated levels. Perhaps we're trying to diagnose an individual with depression and they score high on that scale. Then we can subsequently use further tests after treatment to see if there's any change on the 10 scales that are identified on the visual below. So this isn't necessarily the only method of diagnosing. You could theoretically diagnose without taking this profile, but it is one of the steps that you could potentially use in diagnosing. And of course, you would use this test in combination with the information that you would find currently at the point of recording this video in the DSM-5.